So the scope of this presentation is about the overview of COVID-19, the diagnosis and the treatment algorithm. Okay, so as we've all heard about COVID-19 in the news, it started somewhere last year, late last year. And COVID-19 is a novel virus, that is a new virus, which has the potency in causing severe acute distress. How does COVID-19 happen? COVID-19 is transmitted when you get closer to the droplet of someone who is infected with the virus. And the clinical presentation of COVID-19 is mainly like the common flu to a severe pneumonia syndrome. And when it comes to the pathophysiology of the COVID-19 virus, once the virus gets into the lungs of the victim, the virus attaches itself to a receptor of the lung, and the receptor is responsible for the angiotensinogen converting enzyme type 2. So once the virus binds to that receptor in the lungs, it affects two cells of the lungs, the goblet cells, which are responsible for producing the mucus, and the mucus prevents the lungs from getting dry. And it also affects the ciliated cell of the lungs. The cilia is like a broom which sweeps off bacteria or any foreign material in the lungs outside the external surface. So when this COVID-19 virus gets the chance to enter your lungs, it attacks those cells. And once it attacks those cells, your body naturally responds to it. It sees the virus as a foreign material, so it mobilizes all the soldiers of the body. And once these soldiers are mobilized, they fight against it. And sometimes the immune system is overwhelmed. Sometimes the immune system is overwhelmed. Once the immune system is overwhelmed, it starts attacking the cells of the lungs, making the lung become stiff. And this is where we end up having this acute respiratory distress. And this is where the symptoms start. And the symptoms include fever, cough, and dyspnea, that is the inability to breathe. And the complication of COVID-19 is not just limited to the lungs. It causes a multiple organ failure. How does this COVID-19 cause a multiple organ failure? Once the lung is attacked, respiration is inhibited. And once respiration is inhibited, there's a silent hypoxia. And once there's a silent hypoxia in the body, the cells of the other organs begins to die. Okay, so what is the role of us as biomedical scientists? Because it looks as if everything I'm talking about this time is just about clinical, and the doctors and the nurses are the ones who see this kind of presentation. So what is your role as a biomedical scientist? In COVID-19 diagnosis, the role of the biomedical scientist is not just restricted to the diagnosis, whether positive or negative. The biomedical scientist plays a critical role or a critical factor in diagnosis, in monitoring, and also confirming that someone is cleared of the virus. So with the first investigation to order, when you have COVID-19, these tests are before us. We have the pulse oximetry. Pulse oximetry is usually used to check for oxygen saturation of the body, because once one is infected with COVID-19, respiration becomes hard. So therefore, there's limited or restricted amount of oxygen in the person's system. So this pulse oximetry is just used to measure the oxygen saturation of the infected person. And people, or the doctors and the nurses, are able to see this clinically by a term called cyanosis, where the people begin to turn pale and bluish in color, which is a sign showing that there's less oxygen level. But I'm not sure you want the doctor to treat a patient blindly. yes, it might be that there's less oxygen supply to this patient, but it could be any other disease. So this is where the biomedical scientists come in. We provide evidence-based medicine. And what other tests do? We do arterial blood gases. So initially, when I started with the pulse oximetry, I was talking about restricted flow of oxygen, restricted respiration. So the essence of the arterial blood gases is to check for hypercarbia. When I talk about hypercarbia, it's about high level of carbon dioxide in the blood of the person. Bear with me. It looks as if someone has raised a hand. I'm not able to see the chat, but Sami, if you could please handle the chat section for me. So yes, back to what we're discussing, arterial blood gases. So it is to check hypercarbia, that is the high levels of carbon dioxide in the blood of the individual who is infected with COVID virus. And how does this happen? In COVID, as in COVID infection, the patient has his or her respiration restricted. And we all know that when one respires, carbon dioxide is exhaled and oxygen is inhaled. So once there's a restricted respiration, carbon dioxide accumulates. And in the body, carbon dioxide usually combines with water via carbonic anhydrase to produce carbonic acid, which then dissociates to form bicarbonate and hydrogen ions, which are responsible and serves as a buffer to regulate the pH of the blood. So once carbon dioxide accumulates in the system of the body, it ends up causing metabolic acidosis, which is fatal to the health of the individual. And what other tests do we do as biomedical scientists? We do full blood count. You know, full blood count is used to check the health of one's blood. And typically in COVID patients, you realize that you have lymphopenia, that is low levels of lymphocytes. And in the ideal situation, we all expect as scientists that when someone is infected with a virus, lymphocyte levels should increase. However, that's not the situation in a COVID patient. In COVID patients, neutrophils are rather high. So they have leukocytosis and lymphopenia. That is, there's a high ratio for the neutrophil to lymphocyte. And also in severe diseases, we have thrombocytopenia, where we see low levels of platelets in the individuals infected with COVID. And also when we come to biochemistry, because you know, biomedical science is a multidisciplinary career. All that I spoke about, the pulse oximetry and arterial blood gases, are usually point of care tests. Full blood count or complete blood count are for hematology. And when you come to clinical chemistry, we do a comprehensive metabolic panel. That is where the kidney function is assessed, the liver function is assessed, the cardiac markers are also assessed. And it has been observed with COVID patients that they have high level of CRP, that is C-reactive protein. And C-reactive protein is an acute phase protein, and it always shows up when there is an inflammation or there is an infection. So with COVID-19 infected patients, their CRP can go up to 600. And that was the first time I saw a CRP shooting like this. I was shocked. Yeah. Then with their liver profile, you realize that in the severity of the disease, the liver enzymes are elevated. And also, sorry, someone has raised the hands.
I know. Can you hear me?
Yes, Sammy.
Can you please make me a co-host so that I can add people to the page, to the meeting?
So how do I make you a co-host?
Click on my name and then select make as admin.
Okay,
So that I can help you with adding people.
okay. Mm, Sammy, where is your name?
It's question.
Okay, I've seen your name.
So just click
Okay, double click. Oh, I see a
sorry.
chat instead.
No, like click on my name
Mm-hmm.
and then you see make us admin there.
Okay, I can see more. Make host. Okay.
Yeah. Okay, so you can continue.
Okay, so with the kidney functions too, we realize that their urea and creatinine are shooting, which could even result in an acute kidney injury, because acute kidney injury is calculated from the baseline creatinine level. So if this patient has had a lower creatinine level before, once they have COVID-19, because of the hypoxic condition that can affect the kidneys, the creatinine level could shoot. And when AKI is calculated, it always flags up as the patient having an acute kidney injury. Yeah. So blood and sputum culture. COVID-19 is a pandemic now. However, we've had several viruses which shows relatively the same symptoms like COVID-19. So blood and sputum culture are done by the biomedical scientists in microbiology to rule out other bacterial infection that could be causing the same symptoms as COVID-19, because we don't want doctors to treat our patients blindly. So we come to the gold standard. Everything I mentioned above is used to sort of monitor the patient to find out any underlying condition for the patient. But the gold standard for diagnosing COVID-19 is real-time reverse transcription polymerase chain reaction. It sounds so long, such as the process as well, because the process is also long. Because even though you can automate most of the tests up there, PCR, a bit of it has to be manual in terms of the extraction of the RNA of the COVID-19. So how is this Rt-Pcr done? So when a patient presents to the doctor with the symptoms of COVID-19, a nasopharyngeal sample is taken. It's just a swab that is taken from the throat and from the nostrils as well. So these samples are transported to the COVID labs, because those labs are specialized to deal with COVID alone. So these samples are transported to the COVID labs. And once the sample gets to the COVID lab, the virologist receives the sample and starts with the deal. And what is the deal the virologist does with these samples? The RNA of these virus is extracted from the sample. So once the RNA is extracted, there is this enzyme called reverse transcriptase. It transcribes the RNA to a copy DNA. So once the RNA is transcribed to that copy DNA, it is then amplified by the Taq polymerase. So once it is amplified, the PCR is able to measure the concentration or the amount of the DNA for the COVID patient, and the amount of DNA detected could quote for either a positive or a negative result. So how is this DNA amplified? With the Taq polymerase, once it is amplified, it has to be counted in terms of the concentration. So it uses fluorescence. So the method for the PCR is fluorescence once the copy DNA has been amplified. And also you can use chest x-ray for COVID-19 diagnosis, but it has not been stated as the gold standard. And this one, I leave it to the radiologist. They are scientists as well, but they are not biomedical scientists. And our scope of discussion is limited to what a biomedical scientist do. There are investigations to be considered as well. That is the CT scan of the chest. I leave it to the radiographers. But serology is also to be considered by the biomedical scientists when it comes to the investigation of COVID-19. Serology, we all know as antibodies, mostly immunoassays, antibody antigen reaction. But in the aspect of COVID-19, it's more of targeting the IgG, IgM of the COVID-19 virus. So that is what serology is about. And there are emerging tests that are coming up, the antigen test. And this is where the biomedical science are in the phase of validating this test to be rolled out so that it can be used. The antigen test is mostly about checking whether there is an antigen in the patient's serum or not. And it is a rapid test kit, and it usually uses the technique immunochromatography. That is a combination of chromatography with immunoassay. So the immunoassay deals with coding an antibody that is specific for the antigen of the COVID-19. So once there is an antigen in a patient's serum, it is able to form a complex with the coated antibody. And once that complex is formed, with a technique of chromatography, which is usually color, it shows whether the patient is positive or negative. But they are emerging tests, so they are still in the process of validation. And it is a biomedical scientist that is validating. It is not your doctor, neither is it your pharmacist or the nurse. It is a biomedical scientist in this phase. And some emerging tests are also reverse transcription loop mediated isothermal amplification. This is similar to the real-time PCR. However, this uses a constant temperature, and also the amount of DNA or copy DNA that is produced or amplified is higher in this test than the real-time PCR, making this test more specific and sensitive in the diagnosis of COVID-19 and lung ultrasound. I leave it to the radiographers because we are not radiographers. So, as I said, it is the role of the biomedical scientist to differentiate the COVID-19 from these other viruses or bacteria like the avian influenza, severe acute respiratory syndrome, SARS, the MERS, because they produce the same symptoms, the same clinical features. And you don't want the doctor to be poking or giving any medication that is not right for this patient who is infected with COVID-19. So then we say, okay, after the biomedical scientists have diagnosed or found out something for the doctor, their role ends. No, the role of the biomedical scientist in the containment of COVID-19 doesn't end anywhere. It's in a cycle. It's a cyclical. It moves and it moves and moves. It's never ending. So when we have suspected COVID-19 patients, isolation and infection prevention and control procedures are taken. And before isolation and infection prevention control procedures can be taken, the biomedical scientist has to hop in here and help with the diagnosis. So you'd either have to let the doctor know the patient is positive or negative. So that is the role of the biomedical scientist. Then the monitoring. Yes, the patient will be isolated, the patient will be monitored. However, the biomedical scientist plays a critical role here with the monitoring, because as the patient is being monitored, their samples are being taken day in, day out. And if you, as a biomedical scientist, work on a patient sample and you realize that, oh, there's low platelet level, oh, ferritin is increasing, oh, the lymphopenia is getting to the extreme, then you can just prompt the doctor that, yes, we are monitoring, this is the situation, so this patient has to be hospitalized. So even in a suspected COVID-19 patient, it is up to the biomedical scientist to help the doctors to decide that this patient has to be hospitalized. Because some people can be walking about asymptomatic, but something might be happening in them. COVID could be a silent killer in these people. And the biomedical scientist needs to hop in here by giving the doctor an evidence to say that, oh, even though this patient is not showing any symptoms, I think we need to put this patient on a ventilator. Then in empirical antimicrobials or antibiotics that are given to COVID patients, some of these antimicrobials are toxic when they exceed that therapeutic range. So it is up to the biomedical scientists to be able to monitor and check the levels of these antimicrobials in this individual. Like gentamicin, when it goes above a certain limit, could cause kidney failure and all those stuff. So the biomedical scientist has to check the level of antimicrobials such as gentamicin, theophylline, in the patient's serum and prompt the doctors if the results are going beyond the therapeutic index so that the doctors can adjust the dosage of antimicrobials for this patient. And supportive care, yes, we support them behind the scene because we may not have direct contact with the patient, but we have contact with their samples. And once you have a direct contact with a patient sample, there's a patient behind the sample. So indirectly, you are supporting them. And antipyretic, we said most COVID patients have fever and all those stuff. So some of them tends to take paracetamol every time they feel the fever, the headaches, the shivers. Yes, it is good they take, but paracetamol at a certain dose can be hepatotoxic. That means can cause harm to the liver. What do we do as a biomedical scientist? As biomedical scientists to curb the toxicity of paracetamol, we check paracetamol levels. And once it is greater than 10, we know there's an overdose happening there. So we prompt the doctors as soon as possible so that they can start with treatment by giving them N-acetylcysteine, which is good, however, has a side effect. And yeah, I've had this experience before. I checked the renal profile of a patient, and this patient had creatinine of 32. And previously, that is the day before, this patient had a creatinine of 83, and AKI was flagging up, acute kidney injury. So I'm like, oh, why is this happening? Because someone cannot have a creatinine level of 83 today, and the next day is in the 30s. It doesn't happen that way. So what does a biomedical scientist do? Then I saw, overdose of paracetamol. I'm like, okay, as a biomedical scientist, how is overdose of paracetamol related to creatinine levels? Then, from the different study on research, it is known that N-acetylcysteine interferes with creatinine estimation in patient serum. So it can let someone have depressed levels of creatinine. So then I found the word, I'm like, this patient had creatinine of around 30 today, but yesterday's creatinine was 83. So I asked the nurse, do you expect such a result from such a patient? And she was like, I don't know, let me hand you over to the doctor. So I spoke to the doctor. The doctor was like, how can that be? I don't know what is happening. But then as a biomedical scientist, because our scope of knowledge is broadened, we could input and advise doctors that, I think it is the N-acetylcysteine. Is the patient on N-acetylcysteine? And the doctor said, yes. Then like, okay, once that drip is finished, take another sample from a different arm, or if you can't use the different arm, just take it from the same arm, but let's say after 15 minutes of the infusion. Then later on, the sample came to the lab, boom, and the creatinine levels was normal. So this is where a biomedical scientist plays that critical role by helping our team, like the doctors, the nurses, the pharmacists. Then they take antitussive, that is a cough syrup, if they are coughing or anything. So with confirmed cases, it's similar. They use a similar means, isolation. However, because these patients are having the severe forms of the diseases, some are given, how do we call it? oxygen, some are put on ventilation. However, if someone is put on ventilation or given oxygen, the biomedical scientists still have to come in because you have to check the oxygen saturation level for them. So yes, we hop in as well. And some are given venous thromboembolism prophylaxis, which in quotes, like people with COVID-19 virus, they end up having clot in their lungs and in their vessels. So some of them really have, they end up having DVT-like syndrome, like deep vein thrombosis, not necessarily deep vein thrombosis, but because clots are being formed in the vessels, the bloods are not able to flow properly. So some can even result in pulmonary embolism. So what does a biomedical scientist do in this aspect? So in terms of the venous thromboembolism associated with COVID-19, the biomedical scientist is expected to do a D-dimer test. A D-dimer is a fibrin degradation product which occurs or which comes into existence once the common pathway, the fibrinogen, is degraded to form fibrin to form D-dimer. And D-dimer is not a confirmatory test for venous thromboembolism. It is just to rule out venous thromboembolism. So the sample for this patient gets to the biomedical scientist for a coagulation strain. That is, we do the prothrombin time, the APPT, fine. But we are looking at D-dimer now. So the patient runs the D-dimer test, and D-dimer that is greater than 500, the biomedical scientist phone it as soon as possible to the requester or the clinical team so that the prophylaxis can be started for such a patient. And after the prophylaxis have been started, the biomedical scientist is also expected to help in the monitoring of the prophylaxis because some of them could be toxic to the other organs of the body. So with the prophylaxis, they do tests like INR, APTT, prothrombin time. And when INR is greater than 6, boy, you have to call the requester because something needs to be done with the anticoagulant therapy. So in conclusion, what I would like to say that the role of the biomedical scientist cannot be relegated to the background, not at all, not now and not in the future. Because we see everyone clapping for the nurses for their gallant role, but evidence-based medicine is fundamental to diagnostic medicine. And biomedical scientists serves as disease detectives for medicine. And as biomedical scientists, what are we supposed to do in this time? This is where we need to maintain our professionalism. Professionalism means what? We need to be aware of quality procedures that happens in terms of making sure our analyzers are running fine and producing accurate results. If I mean our analyzers are running fine, what do? We have to make sure we do the necessary maintenances because biomedical scientists, in quotes, sometimes become biomedical engineers when you work with big analyzers. You don't wait for your engineer to hop in. Because the analyzer is yours, you have to know the analyzer because you work with it. So we have to make sure the necessary maintenance that needs to be done on the analyzers are done when they are required. And also make sure before we run our patient sample, quality control has to be done before the run of patient sample. And this is an indicator to ensure that our analyzers are producing the reliable result for these doctors to decide on, because they are waiting for us to decide if a patient will die or live. Is not really about a doctor's negligence. It is about a biomedical scientist's negligence. And we have to make sure that our tests are done in timely manner. Our turnaround time should be shortened as possible so that we can let the doctors know what is happening with the patient so that they can do their best to make sure the patient survive. And also, we have to make sure that we are aware of everything we do with regards to the test. If there's any non-conformity, we have to make sure we pause everything and hop in with any corrective measure to ensure that our patient's health is first. Because in the field of biomedical science, integrity has to be your sure word. Integrity is what you do when you don't see the patient. Do you sit there and wait for your patient to die because, oh, I'm not seeing the patient, I'm seeing a sample? Behind the sample is a patient. The patient could be your friend, the patient could be your family member, the patient could be your husband, the patient could be someone who would become somebody in future. So it is expedient that we take our profession seriously. And to end this, biomedical scientists or biomedical science is not just limited to the lab. Biomedical scientists are the ones helping to design the test protocol needed for diagnosis of COVID-19. Biomedical scientists are the ones validating the test. And also biomedical scientists are the ones who are helping with the discovery of vaccines and also with helping with the prognosis of this disease. And the last thing I would like to say, that your biomedical scientists can ensure that your lockdown is over. And how do they do that? They do that by scaling up their test so that as many people as they can be tested for the government to know that yes, they have herd immunity, so lockdown can be over. So in short, or to end it, I say good job to all biomedical scientists all over the world doing your best, even though it looks as if you are in the background. But we know that you are the bedrock of medicine. We know that you are the heartbeat. And without you, the pharmacist cannot work properly. Without you, the nurse cannot work properly. Without you, the doctor cannot decide. So be proud of the profession you've taken upon yourself and ensure that even in this COVID season or after COVID season, professionalism will be seen in everything you do. Thank you.
Thank you very much. Um, I guess we're all grateful for you spending time with us and then sharing this presentation with us. Thank you very much and God bless you. The meeting was supposed to last for 40 minutes per the basic Zoom meeting settings, but funny enough, we've been given unlimited time. So if any one of us has any questions they want to ask the presenter or the facilitator, this is the time you can ask any questions you want to ask. People are still joining. Sorry, you are late. The presentation is over. Sorry, we did a recording of it, so maybe later on, we will share it on the various platforms. But as it stands now, those of us who took part in the presentation, you can raise an arm and then you unmute your mic and then you ask any question you want to ask the presenter. Thank you. We will give ourselves about 15 to 20 minutes to ask any questions you want to ask, then we end the meeting. If there's any question, you can raise your arm or you can unmute your mic and then you talk. Okay, so I think I would ask the first question. Madam Presenter, Ms. Ohinoa,
Yes.
my question is related to the viral affinity for the what do you call it? The type 2 cells. What's the name of that thing? The type 2 cells in the lungs, right?
Mm-hmm.
The goblet and then the ciliators or the type 2 cells. Yes. So my question therefore is, um, what is the need for ventilators in this case? What is the need? Because it is not as if the person is lacking oxygen like directly. The person is not lacking oxygen. It's not like the person's hemoglobin is not able to bind to oxygen. You understand?
Mm-hmm.
Um, do you think the right approach to treatment or to monitoring of this condition, even though we don't know much details about it, is to target how we can reduce inflammation in the lung cells, or it's linked to oxygen supply by ventilators.
Okay, so with the COVID-19 disease, before we didn't know much about it because scientists had not researched into it. So it was more of a supportive therapy. So the oxygen in itself is not killing the virus or taking the virus out of the body, but it is giving enough oxygen in the body so that hypoxia cannot happen. Because once hypoxia is happening with COVID-19, other organs in the body dies. And once they die, it get infected, your kidney gets, like your kidney dies, your liver is dying. So it's more of a supportive therapy. However, scientists have researched that dexamethasone, which is used in asthma, helps in COVID-19. So that is what they are using now for people with severe COVID-19 disease. So I get you. The target should be reducing maybe the binding of the virus into the angiotensinogen converting enzyme type 2 receptor in the lungs. That is the perspective I am coming from. That as we know the pathophysiology of this disease, we should target on the various aspects of it instead of supporting. However, since everything is still in the primary phase, we would keep supporting patients. So oxygen in itself is not curing the disease, but it's more of a supportive therapy.
Okay.
Is that okay?
Yeah, sure. The floor is still open for anybody who wants to ask a question. Just unmute your mic and then you ask a question. We are waiting for us all. Anybody who has a question to ask the presenter, or did everything sink in right? No questions? Okay, so I would ask my second question. In relation to the FBC results,
Mm-hmm.
I don't know if you can explain a little bit further as to the leukopenia and lymphopenia, and then thrombocytopenia that is evident in COVID patients. Like, I mean, for the time being, that is what they've realized. Are you in the position to explain like that why it is so?
Well, I'm not in the position to explain why it is so, because it is the body's mechanism. But from a scientific perspective, which stands to be approved or disproved, because it's a hypothesis, I'm not concluding. Probably the virus coats itself in the body in such a way that the immune system sees it as a bacteria, and in that case, producing more neutrophils more than lymphocytes. Because we all know as scientists that in viral infection, lymphocytes are supposed to be elevated, but in COVID, it is not so. So as a scientist, I would bring it to the board that I think, but that is not true till I have an evidence. So I think the virus mimics itself to look like a bacteria to the immune system, and then so that the immune system ends up coating more of neutrophils. So that is what I think from a scientific perspective, but it can only be true after research has been done.
Okay. The floor is still open. Anybody who wants to ask questions, there's a time. The presentation was on the role of the biomedical scientist in COVID. And then speaker was Ms. Sohinowa Ifum. She talked about so many things. She touched on several things concerning COVID treatment, COVID management, COVID diagnosis, and everything. But she was more centered on the role of the biomedical scientist. So if there is any question any one of us have for her, there's a time. Just unmute your mic and then talk if you want to ask any questions. Okay, so we are going to assume that everybody is okay with the presentation and we've all understood what was said today. And once again, thank you very much, Ms. Ohinua Efun, for this wonderful presentation. We believe the next time we call on you, you will be able to deliver a bigger one. There's going to be another presentation, not today, but in due time. It will be communicated to the various pages so that whoever wants to join can also join in. If there is no questions to be asked, I guess we would end the meeting here.